Tinoco. Hello everybody, kia ora. Welcome to New Zealand Telehealth Leadership Group second webinar. We're really proud to be presenting this second webinar to you, and thanks so much for everybody who joined us 2 weeks ago. The New Zealand Telehealth Leadership Group, for those of you who don't know, is an advocacy group which advises the Ministry of Health, and we're really pleased to be supported by the Ministry to provide you with these webinars also. Now we've got a really great panel, and I'm not going to take up any more time. We've partnered this session with the wonderful folk at Health Literacy and Health Navigator New Zealand, and Susan Reid is going to moderate for us today, which is wonderful. She's the Director for Health Literacy New Zealand and has a broad experience in law, health literacy and in equity. Susan, all yours. Thank you so much.
Kia ora, Ruth. Kia ora koutou. Called Susan Reid tēnei. I'm very pleased to be able to moderate this conversation tonight, and I'm looking forward to hearing from the panelists and getting all the questions from the attendees, and we're going to try and answer as many of them as we possibly can. It's widely acknowledged in New Zealand that we have an inequitable health system, and so what we're focusing on tonight around telehealth is how is it being used, where it is appropriate, and how it's being helpful. How does it improve access and timeliness of care? So what we're going to do is I'm going to ask each of the panelists to introduce themselves. They've got 3 minutes to talk about how they're using telehealth, what they're finding is useful, who is it useful for, and any barriers, and then we'll come to the questions from the panel. So the first person to introduce themselves is Amiel. Kia ora.
Kia ora, ngā mihi nui ki a koutou. Ko te whānau apinui toki iwi, ko Amiel toku ingoa, tēnā koutou katoa, and whakalofalahi atu ki a tōtulu osi. My name is Amiel Ikihele. I'm a registered nurse, the Innovations Lead for Moana Research, a PhD candidate at the University of Auckland, a wife, a mum, daughter, elder at Mangere Pacific Island Presbyterian Church. And I share with you all of these different roles first because it's important to highlight as Pacific and Māori individuals that we come into spaces with different experiences and contexts. And many of us have many roles and wear many hats, and both within our professional spaces as well as within our community and family spaces. And depending on context, a different hat will be worn, but we still carry a lot of these experiences with us, which helps us help shape our worldview as well as our approach to work, just like our kaupapa tonight. And it is a privilege to be in this space again tonight because especially with all of these wahine toa, to share tu tala noa, tu tala whiti kōrero about this important kaupapa which affects us in different ways, both positive and negative. But I do hope our discussion tonight will leave everyone feeling encouraged that despite the challenges, we should always acknowledge that with challenges comes growth. And we hope that there are opportunities for everyone here to change our current practice so that we are able to reach more communities who find it difficult to either connect through telehealth as well as in person. So tonight I do bring a Pasifika lens and a community and consumer lens about the experiences of telehealth because I know it varies across the spectrum. And when we think about telehealth from a Pasifika perspective, it's really important that we think about context, and that's both from a cultural context as well as a family context, because if we think about a spectrum with 0 being no digital skills and 10 having digital skills, everyone's journey is different along that spectrum, and there are possibly biases about digital use among Pasifika communities, but we do need to acknowledge that everyone has a different journey along the continuum of becoming digital health included. But thank you to Telehealth New Zealand for making this an important topic tonight, everyone who's watching at home across the motu. And just a key component that when we think about cultural safety, telehealth, we need to think about cultural safety, because at the end of the day, it's the consumer which will tell us whether or not they've been delivered culturally safe care. And as health professionals and developers of different platforms, we really need to listen to our communities and really listen to the diverse experiences and adapt accordingly. So thank you, everybody, and ngā mihi.
Kia ora, Amio, before we move and introduce Justine, I just want you, because we've talked about this before, just to very briefly talk about your experience at screening at some of the community-based assessment centres and the barriers that you encountered for whānau that you were dealing with there in terms of being able to text them the results and things like that.
Yeah, so I work also at the Otara Community Screening Centre, and we're finding that with a lot of the individuals who come through to get screened, regardless of age, there is a barrier of mobile phone access. So when we're texting individuals, not everybody has a mobile phone. The majority do, but there are still pockets that don't have a mobile phone. So we do find it difficult to text them results from their COVID screening swab. So then we resort to phone calls, which is just as efficient. Then if they don't also have a landline, then it's delivering their results to their home address. So again, just different spectrum of access for individuals. But yeah, that's us at the Otara screening site.
Kia ora. Thank you. Justine.
Kia ora everybody, malolele, talofalawa, whakalofalahi atu, kia orana. My name is Justine Soui. I'm Tongan, I'm a GP in Te Aratu, and I'm also the Associate Clinical Director of Pacific Health for ProCare. Just lovely to be here tonight, and just as Amma was sharing, you know, there's a lot of diversity with Māori and Pacific, and so in terms of the clientele that you have, you know, there's not one size that fits all. We come in many flavors, many spectrums. And so just my experiences is that I've quickly had feedback from both my Māori and Pacific patients that they love telehealth. A number of them do, and we only use the telephone where I work, and a lot of them appreciate not being able to come in. For some of the mums, it's just having to not have to sort of prepare for 2 hours, you know, to get the kids ready, bring them all in, take time off work. For a number of our patients as well who work, you know, as many of you know, they can't get the time to take off. A lot of our patients, you know, can only come in the weekends, and having access to telehealth, just a phone call, you know, they can make the time to ring in and have their health cared for. For Pacific and also for Māori, we've just got to realise that there's diversity. So with the Pacific, you've got New Zealand born who are quite tech savvy, you've got our young people, and then you've got our older group. And I think that's for both of our cultures. And so you have to realise that you can't assume. You can't assume that one group will be the same across. So you might have an older kaumatua or older, you know, grandmum who has a smartphone better than more flash than you do, and they really know. They ring the relatives in America, in the islands, up north, and so just I would say don't assume. You know, you just touch base with your patients. Some of them don't have any of that, and they just have the phone. And I think everything is okay, but it's really finding what is most comfortable for your patient, what they feel comfortable. We also find that conference calls are a very good way to screen, and you can treat the whole family in a shorter period of time because you're just handing the phone around. And in terms of chronic care, it's just great. You know, it's just like you're all sitting in the room. Sometimes when you guys need a hui or a meeting for the family, well, they've got the luxury of their house and you're the invited guest. And so that's fantastic, you know, to be able to use technology that way to do, you know, screening, health screening, and all sorts of other stuff. So I think from my experiences, I think it should be incorporated as part of normal practice. It should be given as an option, and whatever, you know, options you have for telehealth, whether it's video, telephone, email, it should be all in the spectrum. It's your role as the health professional to navigate and to have the skills to know when you have to shift from the phone to a video to an in-person consultation. And so just going to quickly touch on some of the barriers. And so with our non-English speaking patients, you know, health literacy is even poorer, because they don't have the luxury of giving you the non-verbal cues, you know, face to face. You can't read them, and that's pretty difficult. And so that's an area that I just caution, and I just think that you have to use the skills. I've got a patient of mine who's Samoan, and he was trying to explain what sounded like vertigo. I'm Tongan, and even in his basic English and even in my basic English, you know, I had to make a call whether to bring him in. And so I think be tender with our Māori and our Pacific patients. You know, at the moment we're going into level 2, they're missing out on the hug of the receptionist and the nurse, you know, to sort of greet them, and you're it. And so you really have to shine for them. And so, you know, just bring in that touch base with them where they're at. You know, so it's, for some of them it could be really hard, and you're the person just to say, how's it going? You know, just even raising stress. So just make sure that when you are sort of, if you're on the phone, if that's all you have, slowing down your English. For our people who are bilingual, they don't have options of colourful wording to describe things. So I would say just keep things basic. And, you know, we look at Healthline and Lifeline, which have been going for many, many years, and the success of how they have saved lives. So it's only natural that, you know, opening it up to the wider health community is the way forward. I think that's all I have to share at the moment. Great to be here. Malo Alpito.
Kia ora, thank you so much, Justine. So the next person on the panel is Leanne Carew. Kia ora.
E rere kau mai te awa nui mai te kāhui maunga ki Tangaro ko au te awa ko au. Tēnā ka tuku te mihi ki a koutou e whakara mo mai ana. Mai te tai uri o te kāhui maunga rere atu ki te moana o Punahau. Ko te karutukunga o whānau, ko Leanne ahau, nō reira, kei te mihi atu rā. Kia ora koutou, I'm Leanne Carew. I'm a pharmacist prescriber working in general practice. I'm lucky enough to work in a small rural general practice, and also in an urban marae clinic with amazing people. So kind of diversity there to start with, which does enable a lens that you know, helps feed some of what I'm going to talk about tonight. And great to have Amiu and Justine's beautiful introductory kōrero around diversity. I certainly endorse that commentary. I mean, health should never be about one answer, or one size never fits all, and it never fits all for everybody all of the time. And as Susan was saying, our health system to date has been largely premised, I guess, almost on a bit of a checklist. You know, here's our phone number, here are our hours, kind of 8 to 4-ish. Here's our appointment template, come and see us. And I realise that's, you know, perhaps intended a little provocatively, but so we sit almost holier than thou for people to come. And I do preface all of my commentary in that I have a luxury that GPs don't have. I have a 30-minute time slot, but on the whole, the system has been built on 15-minute appointments in which your notes must be written and your referrals done, etc., etc. So it's not news that it has its limitations, and some people fare considerably better in said system compared to others. In terms of telehealth, my observations and engagements over the last couple of months have seen a web, I guess, of multiple layers of yes, barriers that have been mentioned, and of things that people may not have considered, but also of some merit. And I think we should always be about framing and looking to use innovative ways or different mechanisms at different times for different people, and ensure a praxis of continual improvement within that. So I guess as a summary introduction, I would say that our historic application of the health system has not led to equity of health outcomes, or indeed flourishing of well-being, which is why I'm in the game. It's always, it hasn't always, I guess, been about being in the community during the time that people are available, engaging in culturally safe and clinically excellent health interactions. And the upsurge in telehealth has been born out of necessity. And whilst we need to be extremely mindful of its limitations and the barriers for some, we need to recognise there are some positive elements. So I guess it's not dissimilar to what Justine was saying. We need to be astute about when and how to use it. And I'm not sure whether you want me to go on to the barriers and, you know, the positives that I've come across to date, Susan, or whether that's 3 minutes. I haven't been keeping track.
I think you'll find that it's 3 minutes, but is there any one particular thing you want to talk about in terms of, apart from what other people have said about barriers, is there any one thing you found particularly successful in the work you're doing?
Oh, so this, the positive sides of it? Yeah, gosh, you know, I spend a lot of my time proactive reaching out to people by telephone, you know, again, not dissimilar to the others, because the people that I see mostly don't have the device or capability to be able to use video consults, etc. And I guess in my N of 15 trial, I found a really high acceptability with people under mental health services. You know, people with really high social anxiety, or people that might feel like they're being judged, thought that telephone conversations were excellent. You know, of course we need to lay eyes on them at times, and we need to touch people at times, but that was really helpful for them. And also people spoke to me about journeys of health. So, you know, I guess I've been part of that. You might prescribe a medicine and you might do some labs or something, but you may not see somebody for another month. Right. But in terms of proactively engaging with people, they've seen that as a journey, and that's been really helpful for them. They felt like they've been, you know, helped along the way. But I guess the really big tick for me has been around the hours of engagement. I've always seen hours of access a big issue in terms of equity, and, you know, especially in terms of where people are working. At the Marae urban practice that I work at, I recently interrogated some of our data there and looked at people who had chronic conditions, and 55% of people were working in labouring or manual jobs, and a lot of the notes and then my further engagement with people had things like works in a factory all day, can't get in, works on a crane at the wharf, can't get in, on road construction, gone 13 hours a day, you know, that type of thing, driving a truck all over the country. So people find access a really difficult one, and here where, you know, it's a compounding disadvantage. There are people who don't have access, and then, you know, you've got historical social injustice in the context of health conditions. So yeah, it's a very compounding issue, and that was certainly a positive for me during the time session.
Kia ora, thank you. Thanks, Leanne. Kia ora. I'd like to ask Dr. Lily Fraser to introduce herself and tell us about what you've been doing, some innovative things, Lily.
Tēnā koutou katoa e mātakitaki mai nei. He uri a hau no Naitahu, ko Puketeraki ko o tākou ngā marae. Kia ora koutou, my name's Lily Fraser. I'm a GP and clinical director at Tinoco Healthcare, and I'm also secretary for Te Akoranga a Maui, which is the GP College Māori Special Interest Group. So in my work at Tinoco, we have been doing telehealth amazingly. So the context of our, you know, it's been a massive transformation for us. So in the context of our clinic, we are a 10,000 people practice across 2 sites, majority of whom are in Māngere. We have another clinic in Panmure, and we're about 85% Māori and Pacific patients. And we run kind of concurrent booked appointments and walk-in appointments. So we have a cohort of patients who regularly see the same GP, and then we have another cohort of patients who turn up on the day and are happy or able to see whatever GP is on duty in the acute clinic. And so we have been, because of our walk-in style for that particular large group of patients, we have been battling with the kind of question of how do we get people to call first, because they know that they can just turn up. And so as this level 4 happened, or even the week before that really, when we went into being told to go virtual, just like overnight we had this big transformation in the way that people accessed our clinic. And we were really clear that our clinic was still open and people still could come in for an in-person consultation, but actually our preference was that they rang first, and it was just this flood of people ringing. And so we've managed that so that people who have a preferred GP can still talk to that GP and have their telehealth consult with that person, but there is the acute team who can see people just as they come in on the queue. So we've also had fantastic feedback around how easy it has been and convenient, and lots of thanks coming from our whānau about that. But we've also had that that issue of people ringing too late, or leaving it too late because they couldn't get through on the phone lines. And so there's been, you know, that downside of it is that it's been a huge change for whānau, and when they haven't necessarily had the health literacy to navigate the system, the new system, they've struggled and left and waited, and sometimes, you know, a week too late, and they're straight into hospital. So there's been quite a number of people like that. So in terms of the struggle around the technology, so phone has been really easy for us. Video, because we just changed PMS just before COVID, and switched from one provider of portal to another. Access to video has been really hard, and so we've used DoxyMe, and we're still really kind of coming to figure out how to use our portal effectively. But we do kind of hear the feedback that face-to-face is better, and particularly for our wellness team, we have a GP dedicated to wellness. He has been using video consults for probably about a third of his patients, and he definitely feels, and that kind of engagement with their longer consults, it's been much better for people to be able to talk to him, you know, face to face on the video. I think the thing that we have used differently is around Facebook. So we have always used Facebook in our clinic, and so we have a page dedicated around kai. And so we've run live stream wānanga, and we've done that for about 4 years, where we run a support group and it gets live streamed onto the Facebook. And we also have a cooking class every week, which also gets live streamed. And so we've continued that, particularly the cooking class, we've continued that during lockdown. And so there are no whānau sitting around the kitchen anymore, but Jared is still at home doing the cooking and demonstrating that. So that's been kind of ongoing, and still posting things about that to support people with their healthy eating. The change has been that we run face-to-face wānanga every week, usually on site, and those are around wellness, around maramataka wānanga, also around meditation, mindfulness. And so what we've done is we've kind of turned our Turiki Healthcare Facebook page into a wellness wānanga site. And so every morning we have Te Whare Aio doing, it's called Orokorua meditation. It's a Māori form of meditation that is available to everybody. And so we've had, like, some days we have over 300 comments of people kind of saying how this has been impacting and improving their life, and how they really have connected with this way of mindfulness and meditation in a Māori way. And then every afternoon we have maramataka, and I think learning about maramataka and the cycles of the moon and the impact that that has on our environment and our mood and our energy, it's really cool during lockdown, because people are doing a lot of that kind of exploring what's happening immediately on their doorstep. And so he's giving people skills to be able to interpret that. And then we have our, we have 2 Hauora Rongoa practitioners, husband and wife, Wiramu Nia and Leslie, and they come on every evening and do a karakia for our whānau that are watching. And if people want a specific karakia for something that they're going through, they will send that out to them as well. And so that's a way of us, I mean, we still have our on-site karakia every morning in clinic, but that's a way of us sharing that broader than what we've got. I know my 3 minutes are probably up, but I've just got one more thing to talk about, which is, so Tinoco is also a social services provider and a mama and pepe service around support. And so we also run our antenatal wānanga for counties Manukau. And so those are usually a face-to-face 4-hour session in person in clinic. And so they have managed to do those by Zoom. And so they've been doing 3.5 hours by Zoom with these mama and their whānau. And they've run a number of wānanga during lockdown and had 45 participants, cameras, I'm sure there are more people in each camera, participate, and the feedback has been really positive. And it's interesting because that's usually a really practical session. There's like, you make your uku for the placenta and you do lots of diagrams, and so it's really kind of hands-on and interactive, but still, despite being on Zoom, the feedback has been really positive from the wahine and their whānau. And so they've had 45 wahine participate, and I checked in around Zoom access because it was through Zoom and how the administrators had found connecting people with Zoom, and they said none of the 45, none of the people that they offered it to identified that as a barrier, and that all the wahine said, yep, we can do Zoom, and it wasn't an issue. So, I mean, that's pretty, I think, heartening. I know that there are definitely, that can be a barrier for a lot of whānau, but to get 45 wahine engaged in a Zoom wānanga over a 7-week period is pretty impressive, I think.
Kia ora. Thanks so much, Lou. Now we're moving on to the next person on the panel, Dr. Nina Scott.
Tēnā koutou, te uri o Ngāti Whātua Ngāpuhi me Waikato. My name's Nina, yes, and I'm a public health physician and clinical director, Māori Public Health at Waikato DHB, and also chair of Hei Ahuru Mōwai, which is the National Māori Cancer Leadership Group. So Hei Ahuru Mōwai has been working really closely with the National Cancer Agency, which just got stood up just before COVID hit, with 1.5 staff members, I think, maybe 2. And we worked together to put out vignettes for whānau with cancer, because there's a lot of issues around accessing investigation and treatment. And then at Waikato DHB, we've had a really large Māori COVID response with multiple partners. Iwi set up call centres really, really quickly. So did MSD. Māori and Pacific providers were also doing their own outreach call centres, and we at the DHB set up 2 kind of programs. One's called FAR, and it was based on on partway through a randomised controlled trial called Hāti Hauora Tamariki, and it's just a simple screening tool for the whānau of hospitalised children. So we adapted that for kaumātua, and then we got a list of Māori and Pacific over 65 with long-term conditions. We got a whole lot of volunteers to call them. I think probably about 20 people in the call centre. It wasn't really a call centre because it used people calling from their own homes. And they went through the electronic FAR tool, which, we'd meet every day to tweak the FAR tool and to add new services to it. And then as we came up, whenever we met a whānau need that we couldn't resolve, we met as a team, and we did this every day, and we also worked with iwi and other call centres to problem solve together. One of the things that we came up with was that whānau weren't able to connect with medical care. So we developed up the RAP program, which is the So it's a nurse triage who's connected to primary care and secondary care, and and it's worked amazingly well. We've got a group of passionate, dedicated, mostly Māori doctors who are just volunteering their time, and yeah, it's working really well, and we're hoping to keep it going post-COVID. So the aim is not to replace whānau order providers, not to replace GPs. It's to proactively call whānau and link them up to the services that they require. And sometimes that's a GP, sometimes it's a secondary care clinician, sometimes it's a whānau order provider, sometimes it's somebody to deliver kai. Yeah, so that's going really well.
Kia ora, thank you, Nina. Now I'd like to ask Prudence Walker to please introduce herself and talk a little bit about her experiences with telehealth and what consumers are telling you.
Kia ora koutou. Ko Prudence Walker tōku ingoa. My name is Prudence and I identify as a disabled woman. So for some context of why I'm here today, I'm the Chief Executive of the Disabled Persons Assembly, otherwise known as DPA. And for the last couple of months, I've been working first in the Ministry of Health and then the all of government COVID-19 disability communications and accessible formats work. Relevant to this also is previously I was involved with the Canterbury District Health Board Disability Steering Group and the Canterbury Clinical Network Population Health and Access Service Level Alliance. So it's great to be involved in the conversation of equity in a health context and to be talking about equity as a whole issue, so disability included with other issues of equity. So we know that disabled people as a group of people have poorer health outcomes in general. Actually in a lot of areas there's not necessarily a lot of data collected about disabled people, so that in itself is an inequity because we can't identify the needs of a group well. So for many disabled people, the move to provide more telehealth services as a result of the COVID pandemic has been positive. We know that for many people living with, for example, chronic fatigue or mobility impairments, that not having to go in person for a health consultation and being able to easily request repeat prescriptions, etc. online has been of a real benefit. I think one of our staff described, you know, being able to get my health needs met without leaving my house at this time has been a real bonus. Also had the example of somebody who had a back injury not long before lockdown, or a month or so before lockdown, because they were on bed rest for a substantial amount of time before lockdown, and they couldn't get any doctor to talk to them about medication over the phone. And then COVID-19 came and he could, and so that saved him from you know, not having to endure a lot of pain to get to see a doctor and be able to have those discussions to meet their health needs. Equity issues accessing telehealth services, as other people have identified, largely arise out of equity to internet access. If you don't have access to the internet, then accessing telehealth services is problematic. It's also extremely important that telehealth services are hosted on accessible, easy to use platforms, and I'll talk a bit more about accessibility in a minute, because that's probably the other key thing for our population. Disabled people should be provided with accessible information about telehealth services as well, so that they can give meaningful, informed consent. And I think, you know, communication is really a big thing, in relationship as well, because not for all disabled people, but for a lot of disabled people, they may have more complex health situations, or actually just extra added to the knowing that somebody gets you part, which everybody wants, right? And I know that's an issue for a lot of disabled people. The pandemic and lockdown has really highlighted the need to ensure that everybody has digital access, and I know that that conversation is popping up in a lot of areas. And you know, in level 4 is identified as an essential service. So I think that there's probably a lot more possibility in that area that will then benefit a whole lot of things, but telehealth, for example. DPA has identified 3 priority areas in relation to digital inclusion for disabled people, and that is the affordability of that access and devices, so the affordability of an internet connection and a suitable device to use, accessibility of online services and information points. Sorry, I'm just losing myself. And support for people to gain the digital skills if they're not already technologically literate. A recent report identified that only 71% of disabled people in New Zealand reported having internet access, compared with 91% across all the entire population. Voice is really important. Many people still need to be able to access in person for a wide range of reasons, but for example, they may not be able to ensure privacy at home, and the only way they can have privacy to discuss health issues is to have an in-person consultation. But I think one of the big things really is around communication and the ways in which people communicate or need access to information. So perhaps to highlight that, you know, we are all quite aware with the Prime Minister's stand-ups that have been happening, you know, that those are always sign language interpreted. And so perhaps that's more in people's awareness these days. However, there are other formats as well. So, for example, not all deaf people use sign language, and so in a, you know, in a video context, if telehealth consults are happening there, then some people may need captions. There are issues for people who perhaps have learning disabilities, and how do you ensure that people are receiving information in a way that is accessible to them, and that in a way that they're able to give informed consent where that is required. As I said before, you know, any platform hosting telehealth services needs to meet web accessibility standards, and indeed like government standards around that, and be compatible with accessible technology such as screen readers. Yeah, I think that covers about me for...
Prudence, thank you. Thank you so much. So last but not least, I'd like to ask Dr. Wiki Gillespie to...
Kia ora, telemedicine whānau. Ko Ngāti Kahununu tōku iwi, ko Wiki Gillespie. I'm Dr. Wiki Gillespie. I'm a GP at Swanson Medical Centre in West Auckland, and I'm on the Pro Care Māori Advisory Committee. At our practice, we care for just over 7,000 patients. We've got 4 FTE GPs, and we now offer video consults as well as phone consults. We have a patient portal with open notes with about a 50% uptake. We have a blog on our website, and we've got a Facebook page. And we've recently added some video to our Facebook page about how we are caring for our patients during COVID. When COVID hit, we had some really limited telemedicine capacity already set up in our clinic. So we really had to ramp it up to make this as easy as possible for us and our patients. And in making things as simple as possible for our patients, we were hoping that our patients would give it a go. Now, I love an in-person consult as much as the next GP, but I think telemedicine consults do beat phone consults for their added connection to the patient and the window into their home life. Our whānau have used our video consult service and have been really positive about it so far. Now, about a third of my consults are via video consults, and a quick check over the last week actually shows that almost 50% have been with my Māori whānau. My main equity messages are about the importance of relationship and trust with our Māori and Pacifica patients. I do think that telemedicine has the potential to build on our relationships, and we can see our patients more frequently and easily and get us all humming along on a shared path to health because of that connection. And telemedicine has the potential to increase equitable access, I think, to healthcare by reducing reliance on transport or people having to transport them to the clinic. They don't have to sort out childcare or leave work, and they don't have to do battle with the traffic. And for those patients with some disabilities, telemedicine could make seeing the doctor so much easier. And from my end, it's a peek into their home lives where I can meet the extended whānau, the dog or the cat, and with their consent, have a tour of their homes or in their fridge. I've been caring for my palliative patients, doing mental health consults, and the youth love it for contraception. I've looked at rashes and a world of other normal general practice care through video. I've met with newborns and with over 80-year-olds. My other main thoughts are around the barriers that people might have to overcome to be able to use telehealth. I'm learning about this as I go along, be it the lack of devices or data about know-how or confidence. Maybe they don't want me to see into their home, or they're whakamā about the doctor being able to see where they live. I have some whānau who don't have internet access, and we're working with them to get them hooked up with things like subsidised broadband for people who wouldn't otherwise be able to connect. We may also need to teach people about how to use our video connection, and sometimes we're guiding them on the phone while getting them to sign into our online waiting room. I'm also mindful of unconscious bias from our end, assumptions about whether our patients will be able to do a telemedicine consult or not. How the concept is sold is a big part of whether the offer of a video consult will be accepted. It's just so much easier to just organise a phone consult. So it's really important to get your whole team comfortable with the concept, about how it works and why it's good. And it's so that will really help with increasing your uptake of the video consults. Equity in telemedicine is the same as equity in anything. You have to know your data. It's the only way to know if some sort of bias or inequity is creeping in. Who isn't accessing your service? Who is? Start as you mean to continue and code your types of consults. Video, phone, in-person consults. Really important to do that. And my last thought is around how do we know if our service is any good? We've got to ask our patients. COVID has meant that we've had to create a telemedicine service on the hop, and it will be good to get this essential feedback from them about whether it's working for them.
Sort of Wiki, thank you so much. I'd like to get started on some of the questions. I'm looking at the time and thinking, right, we're going to go fast now, she says. So I've got a question for Justine and Lily. So the questions come in about the confidentiality where whānau are sharing a device, and how have you come across that? It might be sharing a phone or sharing another device. Have you come across something where you're concerned about maybe the person you're speaking to can be overheard by other whānau, or how have you addressed those issues?
I think that's an area that we need to do a good piece of work on, because in the same breath, is there consent from that patient, and it goes the other way as well. So they need to be reassured that you're talking to them in a room that's confidential, and you don't have other colleagues who are, within earshot as well. You're not talking in the reception area, and that's the danger about the phone. And so I think it's, you know, you have to develop in your practice policies and guidelines, and so that there is written agreements, you know, whether you're a GP practice or a, you know, sort of physio, and that needs to be, it's sort of a contract, and it needs to be spelled out from the start that, you know, that they're happy and that you're happy as well, so that you don't have surprises either way.
Kia ora. Anything to add, Lily?
My approach is really, like, particularly when you're ringing with results or you're discussing something that's sensitive, is actually just to straight out ask, is it appropriate to talk to you at the moment? Do you need to go somewhere private? So asking that question before you launch into their results, or asking sensitive questions. And so I think it is just being really straight up about that, and making sure that you're thinking of who else is in the environment, because it may be their children, it may be other people. And then, you know, so we use Manage My Health, and so being aware of, we have open notes as well, that with devices, you know, like things can go, people can get into people's email without a password really easily. And so what are you putting in the notes, and what are you allowing to be accessible through Manage My Health? And so using the option to not load things to Manage My Health if confidential matters are being, or sensitive matters are being discussed that you don't want shared with the wider whānau. And so I think that needs to be part of your consideration, as well as saying that, look, I am writing this in the notes, but I do have the option to not make this accessible on your portal if you want me to.
Kia ora. I have a very quick question for you, Nina. It only requires a yes or a no answer. And it's, is RAP available for rural whānau in the Waikato DHB?
Yes.
Kia ora, thank you. Somebody's going to ask you about that later, I'm sure. Okay, somebody, this is a question, Wiki, for you, and also I think maybe, again, Lily or Justine, but we'll start with you, Wiki. So somebody's raised a question. In fact, a number of people have said these questions about phone consultations can be very difficult in terms of reading how people are and their concern and getting a level of engagement. So this person and a number of people's concerns are they could be worried that they're being seen as less empathetic in some way because they're not doing an in-person consultation, or they can't be seen, so their body language can't be seen. So what advice have you got? What's your experience been with phone consultations? It sounds like most of the people you've been talking to, Wiki, are people you know, but what do you think might be the situation when you're talking to someone you know, who's new to you?
Yeah, I think, again, just from an equity point of view, our communities don't have a voice, and it's just the same thing as in the consultation room. So you've got to put the effort, you've got to be intentionally interested in them, and you have to take the time to build the bridge. You have to ask them, how's your day going? You know, you can be general, how's everything at home? You don't have to be too personal, because they're reading you as much as you're reading them. They're thinking, here's this Palangi doctor or this person, why should I relate to them? So you really actually do have to make the effort, you know, say their name, kia ora, build a bridge. Also, you know, take a few seconds to be interested, you know, have you visited the island that they're from? Have you been up north to the marae that they're from?
Right.
That intentional effort goes a long way, because really it's like making a friend. And, you know, it's about relationship building and trust. And so that's the first step.
Thank you. Wiki, have you got any particular comment for that?
I kind of treat my telephone and my video consults just like I do my in-person consults, because I usually spend quite a long time just gas bagging with my patients, which is why I run terribly late all day long. So, you know, a lot of that is like Justine's saying, it's about building bridges and kind of hearing about their lives, which is not about the problem that they're in front of you about.
Right, thank you. Now, I'm not sure.
Oh,
sorry,
cool.
let me go. No, go.
Yeah, I mean, we have a rule at work, which is if in doubt, get them in. And it's okay. Like, I mean, it's great to do telehealth, but actually we can see people in person. And so it's okay to actually say, look, I'm just, I think I need a bit more information or to assess you in person. Please, can you come in today? Because, you know, patients are used to that. They're not going to begrudge you that you've decided to do that. And I think if you're not getting the message clearly on the phone or via video, then it's fine to get them in.
Right, thank you.
I was going to say, Susan, just around that, you know, some beautiful talk about whakawhanaungatanga there, which is of course important, but I think it's sometimes that clinician training around the biomedical approach. And I did have a conversation with a GP at one stage in ringing, and the cultural nuances, and not to focus in totality on what, you know, the clinical red flags. And it was with one of my karawa in particular, who he has a predisposition to talk about rugby whenever he's very unwell. So, you know, when you don't have the benefit of watching him walk to your room, and you're not looking at his colour, and, you know, look, it's discussing dyspnea or orthopnea, or whether or not he's got oozing edema going on, he talks about rugby. So I had to, you know, discuss this with one of our other GPs, one of my colleagues, because in a phone consultation for someone who doesn't know this man, you know, it may have been quite a, you know, different outcome. So yeah, it is those kind of cultural things versus, you know, the cultural literacy versus the biomedical model and clinical red flags as well.
Right, now this is a question I'm going to, Prince, I'm just going to ask you, I suspect I know what your answer is going to be, but this question has come through, and it's a question for everyone, and it may be actually the last question we ask because we're getting close to time. But I'm just going to ask, so this has come through, the question is, should we push for continuing DHB, Ministry of Health funded phone consults after COVID, or push for better access to technology in the community? You know, which is telehealth a basic right? So, Prince, what do you think?
Yeah,
very quickly, she says.
Yeah, as some of the panelists talked about in their introductions, I think it's not a case of one size fits all. So I think as an option, definitely.
Okay. Kia ora. Nina, what do you think about that question? Should we push for, you know, DHB's push for paid consults after COVID?
Yep. I mean,
phone telehealth consults.
Access, you know, access and timeliness of care is inequities in that is one of the biggest drivers of health inequities.
Yeah.
And I think the telehealth is a massive solution to both the access and to the timeliness.
Right. Has anyone else got a short comment on that? Because there's one last question I want to ask Amiel.
That one as well. It was just in regards to access to devices. It doesn't always solve issues, because with access you need to provide the support and the skills for people to navigate those new platforms. And if you're just giving individuals to navigate that on their own, there will be challenges for them. So it's also about what support do they need to then be competent to develop, to then navigate these devices, as well as develop the confidence and motivation to keep using these devices.
Yes.
And the motivation, confidence is really key.
So a quick question for you, Amiel, and then we're, so somebody has sent in a question saying, is there a specific framework tailored to telehealth and tele-rehabilitation that people can use?
No, there isn't. But just what Justine said and what everybody else has said, it's about relationships, and how do you build those relationships with anybody, regardless of age, ethnicity or gender. It's about how do you develop the VAR or the spaces so that people can connect with you, whether it's in person or via telehealth consultations. So if we base our consultations under that premise, then we know that future engagement with individuals will be on a trusting basis as opposed to a transactional type of outcome.
Okay.
Could I just add that it can be scary for our people. So it's, you know, it really is. And so really it's first impressions. It's just the same when you engage a patient in person. So you've got to realize they're scared and they're nervous, especially if you haven't met them before. For us who've had patients for ages, that's fine. But when you're first engaging a patient of Māori or Pacific, you really have to build the bridge, and that'll take you a long way.
Kia ora, thank you so much. On behalf of Telehealth NZ, I would like to thank all of you for making yourselves available tonight and being such a fantastic panelists of Wahine Toa. And I'd like to now hand over to Ruth, who's going to finish off our session for this evening.
Yeah, thank you, Susan. And look, the conversation has been absolutely amazing, and I think that's reflected in the fact also that we've got an amazing audience who are participating, but also we often see a bit of drop off towards the end of a session in these webinars, and you know, we're almost at time to close and there's been very little drop off. So I think that's testament to the topic that we're talking about and the amazing content that you've raised. So thank you so much, and thank you once again everybody for an amazing webinar. We look forward to sharing the content with you.
Good.